जी
So can I start?
हाँ जी प्लीज अपने आप को इंट्रोड्यूस करो
Assalamu alaikum. My name is Nada Khalid. I'm one of the residents here in Habib Latif Hospital, and today I'll discuss a case and then topic of ectopic pregnancy. First, the history of my patient. My patient, Mrs. Huma Bilal, 32 years of age, wife of Mr. Bilal Khan, married for 1.5 years, teacher by profession, currently housewife, lives in Model Town, Lahore, came to Hamid Latif Hospital labor room on 13th of June 2021 at the gestational age of 11 weeks with the presenting complaint of uh, right-sided lower abdominal pain for 5 hours and one episode of dizziness 2 hours back. My patient conceived spontaneously while having regular menstrual cycle and practicing no contraception. Her LMP was 28th of March 2021, making her estimated date of delivery on 2nd of January 2022. She confirmed her pregnancy through urine pregnancy test on 5th of May 2021 when she was overdue by 1 week. She had no history of nausea, vomiting, or any other symptom in that period. But she had an episode of pervaginal spotting on 10th of May 2021, for which she went to hospital and got herself evaluated. She was advised a scan as well as serum beta HCG. Serum beta HCG came to be 985, and on scan there was no gestational sac, intrauterine or extrauterine, but the endometrium was thickened. She was advised a follow-up scan after 10 weeks. She remained asymptomatic through that period. She had a scan on 18th of May showing a right tubal pregnancy 2 into 2 centimeter with no cardiac activity. Her beta HCG was 1580. According to the consultant, she was advised an injection methotrexate, a 50 milligram injection intramuscular, which she had on 20th of May 2021 at the gestational age of 7 weeks. She was advised a follow-up beta HCG on 2nd and 4th day, which came to be 2200 and 1980 respectively. She was advised to follow, but she didn't follow, saying that she was normal and didn't have any complaint for next 3 weeks. On 13th of June 2021, she presented with lower abdominal pain, which was sudden in onset, severe in intensity, and more on the right side, radiating to back. Not associated with any movement. Pain was constant and it was not relieved even after taking painkillers at home. She also experienced an episode of dizziness, but didn't faint it. Dizziness for 1 minute, but didn't faint it or vomit. Now the previous history, my patient does not have any history of diabetes, hypertension or tuberculosis or any other significant past medical or surgical history. She is not allergic to any medicine. Her both parents are diabetic, were diabetic, otherwise no significant family medical history present. Her age of menarche was 12 years. Her menstrual cycle was regular with 5 30-day cycle and average flow. No complaint of dysmenorrhea, menorrhagia, intermenstrual bleeding, or pervaginal discharge. Couple's coital frequency was 4 times per week with no complaint of dyspareunia or postcoital bleed. Her pap smear was never taken and couple didn't practice any contraception. She is a non-addict, non-smoker, having regular sleep, appetite, and bowel habits. She belongs to middle-class family with stable financial background. Now, general physical examination. A young, pale-looking lady having a BMI of 25.7, well-oriented in time, place, person, lying on bed in discomfort but answering my questions appropriately. Her pulse was 110 per minute. Her blood pressure was recorded to be 160 millimeter of mercury. Her respiratory rate was 22 per minute. She was afebrile with a oxygen saturation of 97% at room temperature. There was no cyanosis or clubbing, no jaundice or koilonychia was noted. Thyroid or lymph nodes were not enlarged. There was no pedal edema, bilateral breast symmetrical with no lump palpable in any of the quadrants. So it was an acute emergency, so the examination and the management was going side by side, but I'll explain the examination first and then I'll go to the management and investigations. Respiratory system, trachea was central, normal, vesicular breathing was noted in both the lung fields with no added sound, and lung bases were clear. During cardiovascular examination, apex beat was palpated in left fifth intercostal space, medial to mid clavicular line. First and second heart sounds were audible with no added sound. On abdominal examination, abdomen was flat looking with central umbilicus, no stria, scar marks or visible pulsation was seen. During superficial palpation, abdomen was soft but tender in the right iliac fossa. So because of the pain, we didn't proceed to deep palpation, auscultation or percussion. There was a mild vaginal bleed on the pad. Ideally, vaginal examination should be done for the final diagnosis, but because the patient was tender, so I omitted it.
जी, और next आप चलते जाओ.
जी sir. So my provisional diagnosis is right ruptured ectopic because she's already had the history of, she was a follow-up patient of the ectopic pregnancy, and she also had a scan half hour back before receiving into the labor room with the impression of right ruptured ectopic. So I have the findings on the multimedia. Excuse me, please go connect कर दीजिए.
Patient was admitted on 13th of June.
जी sir.
टाइम भी आपने बताया हो.
सर टाइम मुझे याद है क्योंकि मैंने रिसीव किया था उनको लेबर में अराउंड 6 PM.
बताया था कि नहीं बताया?
नहीं सर, यहाँ नहीं था.
टाइम.
जी सर.
क्योंकि उसके साथ आपका चलेगा कि टाइम आपने कितने बजे का था और कब आपने.
जी सर. Now, here is the summary of my case. My patient, 32 years old, primary gravida. She had an injection of methotrexate for right tubal pregnancy at the pregnancy of 7 weeks for 7 weeks gestational amenorrhea. And then she presented at the age of 10 weeks with the right lower abdomen pain with episode of dizziness with the pulse of 110 per minute and blood pressure of 160. Blood group was AB positive and her previous hemoglobin level was 11.2 with normal renal function and coagulation profile. Her hepatitis was negative, screen was negative. Now here are the ultrasound findings which were on the ultrasound which she brought to the labor room. Right adnexa showed complex heterogeneous area measuring approximately 56 into 54 millimeter with surrounding echogenic fluid. Moderate amount of fluid was seen in the cul-de-sac. Streak of fluid was seen in the hepatorenal pouch. Ultrasound features suggestive of ruptured ectopic pregnancy. Now, when you receive a patient with acute ruptured ectopic, you have to manage it as quickly as possible. Say we started by saving 2 large IV bore cannulas because you've already seen the pulse was 110 and blood pressure was 160, and we attached the IV fluid immediately, sending the essential blood, including full blood count to see her hemoglobin, TLC count, platelet, hematocrit, as well as LFTs, RFTs, and coagulation profile. We asked the relatives to cross-match at least 3 units of blood, and immediately the senior gynecologist and anesthetist were called. Counseling and informed consent for the procedure was taken, and the patient as well as the attendant were informed about the ongoing situation. Meanwhile, operation staff was also informed for the preparation of emergency procedure. She was shifted to operation theatre and she was operated within 2 hours of her reception in the labor room. All the time was that was spent waiting for this gynecologist as well as the arrangement of the blood, and soon the blood was arranged, the patient was shifted to the operation theatre. So the intraoperative findings, emergency laparotomy was done for the right ruptured ectopic pregnancy. During the operation, the intra findings included 1 liter of hemoperitoneum, and there was a right ruptured ectopic of 6 into 7 centimeter involving the full length of the tube. The tube was already ruptured, so there was no point in saving of the tube. And secondly, the other tube, the contralateral tube, was healthy and normal looking, so the consultant preferred to do the self-injectomy. Right ovary, left tube, and left ovary were all normal looking, and so we end up doing right self-injectomy. Now in the post-op bay, she was given complete adequate pain relief as well as vital record for next 24 hours. She received antibiotic cover. Her post-op HB hemoglobin level was 8 gram per deciliter. So she was already transfused 1 blood intraoperatively and 2nd blood post-operatively. Advice was given to follow up with the histopathology report on the discharge and to avoid contraception for 3 months because she had the methotrexate injection previously. So it was the case. If anybody wants to ask questions related to case,
I would suggest to all who are participating in this session to write down their questions or their critique of the presentation, the points that they want to make about what was said extra or what was missed and what was not mentioned, and about the management that has been described before the patient came in that acute emergency. There may be a few points about that which can be raised, and also about the management which was carried out in the hospital. You can make a comment about that as well. Can we have those comments first and then we go on to the slides? How many slides do you have? About 12 more slides?
जी sir. जी sir.
7वीं स्लाइड पे हो तो टोटल आपकी 19 स्लाइड्स हैं.
जी sir.
12 more slides. So do you want to, all right, you can carry on with the rest of your presentation and we'll take the questions at the end.
Okay, sir. So now the definition of the ectopic pregnancy. Ectopic pregnancy is defined as implantation of pregnancy outside the normal uterine cavity. Now we all know that in normal pregnancy, fertilization of the mature ovum occurs in ampullary part of the fallopian tube. Thus, any abnormality in the tubal morphology or function can lead to impaired migration of fertilized egg, including damage to the tubal mucosa, damage to fimbrial end, or internal scarring of the tube. Now, one possible explanation is that poor quality of morula or chromosomal abnormalities can also lead to ectopic pregnancy. Incidence of ectopic presentation is 11 per 1,000 pregnancies, and the maternal mortality rate is 0.2 per 1,000 ectopic pregnancies and 0.3 per 100,000 maternities. Now, there are few risk factors for the ectopic pregnancy, including the tubal pathology, previous ectopic pregnancy, previous tubal surgery, smoking, history of pelvic infection, subfertility, multiple sexual partners, and advanced age. Now, here are a few types of ectopic pregnancy, tubal as well as non-tubal. Now, 95% of the ectopic pregnancy presents as tubal pregnancy, and rest of the 5% as non-tubal ectopic. Now, I'd like to explain the cesarean scar ectopic. The incidence of cesarean scar is 1 in 2,000 pregnancies, and gestational sag. Now, the Cesarean scar happens when a gestational sac or a mass of trophoblast located anteriorly at the level of the internal os in the site of previous lower uterine segment. There is a thin or absent layer of myometrium between the gestational sac and the bladder. Then comes the cervical ectopic with its incidence of less than 1%. Gestational sac is below the level of internal os, and absence of sliding sign on TVS will differentiate between the miscarriage and the cervical ectopic. Now comes the interstitial pregnancy. Now, in interstitial pregnancy, the product of conception located in the intramural part of the tube and surrounded by less than 5 millimeters of the myometrium. There will be an intact junctional zone between the uterine cavity and the gestational sac. Now, the cornual pregnancy, it is usually the implantation of the sac in the congenital abnormal uterus. And it's a very rarest form of ectopic pregnancy, and its incidence is 1 in 76,000. Two other type of pregnancy which are not mentioned here are a heterotropic pregnancy, which is when there is intrauterine as well as extrauterine pregnancy coexisting at the same time. And another is pregnancy of unknown location, which is when woman has a positive pregnancy test, but no intrauterine or extrauterine pregnancy can be seen on TBS. Now the clinical presentation. Patient usually present with the symptoms of abdominal or pelvic pain, amenorrhea or missed periods.
amenorrhea को जरा आमतौर पे नंबर 1 पे ले जाना चाहिए।
जी सर।
Abdominal pain को नंबर 2।
ठीक है सर। Vaginal bleeding with or without clots, breast tenderness, gastrointestinal symptoms, dizziness, fainting, syncope and shoulder tip pain.
तो इसमें अगर आप वापस जाओ तो मैं इसको थोड़ा सा तब्दील इस तरह से करूंगा।
जी सर।
पिछली स्लाइड पे।
जी सर।
ये आपने पहले एमेनोरिया और मिस्ड पीरियड्स हो गया।
जी सर।
उसके साथ देन गिव सिम्पटम्स ऑफ प्रेगनेंसी लाइक ब्रेस्ट टेंडरनेस, नोजिया, वोमिटिंग, वो वाले जो होंगे वो इसके साथ रिलेटेड होंगे, राइट? व्हिच वुड मीन दैट इट इज अ प्रेगनेंसी स्टेट। उसके बाद फिर आप आओगे एब्डोमिनल पेन और पेल्विक पेन और ब्लीडिंग और गैस्ट्रोइंटेस्टाइनल सिम्पटम्स। गैस्ट्रोइंटेस्टाइनल सिम्पटम्स वो तरह क्रॉनिक में ज्यादातर होंगे जब वो उस तरह से इरिटेशन होती है, हेमेटोसील बनती है। डिजीनेस, फेंटिंग और सिनकपी जो है ये एब्डोमिनल पेन के साथ जाएगी। शोल्डर टिप पेन जो है वो जरा थोड़ा सा नीचे इसलिए कि वो जरा एडवांस स्टेज होगी, जब जाके डायफ्राम को ब्लड टच करेगा तो फिर वो शोल्डर टिप। तो इसलिए इन ये जितने आपने 7 फीचर्स लिखे हैं इनका ऑर्डर आप जरा तब्दील करो।
जी सर, ठीक है। Now here are common signs which we can observe while examination, which includes pelvic tenderness, adnexal tenderness, abdominal tenderness, cervical motion tenderness. Although we do not perform the per vaginal examination now, but it's one of the features indicating the ruptured ectopic or acute ectopic. Rebound tenderness, pallor, abdominal distension, tachycardia.
ये इसमें भी अब अगर तुम देखो तो इसमें आपने अगर पैलर को ऊपर ले जाओ तो वो ज्यादा बेहतर नहीं है, बिकॉज दैट इज जस्ट व्हेन यू सी द पेशेंट वो उसमें है। दूसरी चीजें जो है वो जब आप हाथ लगाना शुरू करते हो, there may or may not be abdominal distension. So abdominal distension again is something that you would observe, you see that, right? और बाकी चीजें टैकीकार्डिया भी उधर चला जाएगा और ऊपर चला जाएगा और वो दूसरे फिर नीचे आना शुरू होते हैं। जी सर। इसी तरह से एडनेक्सल टेंडरनेस, सर्वाइकल मोशन टेंडरनेस जो है उनको आप आपस में वो एक ही चीज बन जाती है मोर और लेस। चलो ठीक है।
Now TVS is used as a diagnostic tool of choice for diagnosis of ectopic pregnancy. Its sensitivity is from 87 to 99% with the specificity of 94 to 99%. Now, usually what we note on TVS is an empty extrauterine sac, which appears in 20 to 40% of the cases, while in 50 to 60% inhomogeneous or non-cystic adnexal mass, which is moving separately to the ovary, can be seen. This is also referred to as tubal sign or vagal sign. Now, an extrauterine gestational sac with the yolk sac or embryonic pole with or without cardiac activity can be seen in 15 to 20% of the cases. A pseudosac can be seen, and here I would like to add, serum beta HCG level is useful only for the planning of the management, not for the diagnosing the location of the pregnancy. Now, there are three types of managements of ectopic pregnancy depending upon the situation and the features of the patient. First, we'll discuss the expectant management. Now, we offer the expectant management as an option to the women who are clinically stable, pain-free, and have tubal pregnancy of less than 35 millimeter with no visible heartbeat on TVS. And the beta serum HCG level should be between 1000 to 1500 international unit or less. And an important point, they should be able to return to follow-up. They're advised to repeat beta HCG levels on second day, fourth day, and seventh day. If beta HCG levels drops by 15% or more from the previous value, then repeat weekly until the negative results. And if beta HCG levels do not fall by 15%, stay the same or rise from the previous value, review the woman's clinical condition and seek senior advice for further management. Advise the woman that risk of tubal rupture, need of treatment if the condition deteriorates, time taken for ectopic pregnancy to resolve, and future fertility outcome. They're all likely to be same with the expectant or medical management. Now, the medical management. We offer methotrexate to the woman. First of all, I'd like to add the methotrexate is an injection of 50 milligram, which we offer by 50 milligram per meter square. And we offer this to the women who have no significant pain, unruptured tubal ectopic pregnancy with an adnexal mass smaller than 35 millimeter with no visible heartbeat. Now, their beta serum HCG level should be in the range of 1500 to 5000 or less. As well as they do not have an intrauterine pregnancy meanwhile, and are able to return for follow-up. Advise them that the chance of needing intervention is increased and they may need to be urgently admitted if their condition deteriorates. Repeat beta HCG on 4th day and 7th day, and then 1 measurement per week until the negative results. If beta HCG level does not reduce by 15%, then get a TVS to check for hemoperitoneum and fetal cardiac activity, and then go for the second dose. Now, the surgical management. We offer it to the patient when they have significant pain, when there is an adnexal mass of 35 millimeter or larger, when there is FCA on the ultrasound and serum beta HCG 5000 international unit per liter or more. And if patient is hemodynamically unstable and she does not have any of these features, even then you have to proceed with the surgical management. Now, when surgical treatment is indicated for the woman, it should be performed laparoscopically whenever possible, depending upon that you have equipment as well as expertise. Offer salpingotomy to women undergoing surgery. Offer salpingectomy to the woman undergoing surgery for an ectopic pregnancy unless they have other risk factors for an infertility. Consider salpingotomy as an alternative to salpingectomy for women with the risk factors for infertility such as contralateral tube damage. Inform women having salpingotomy that up to 1 in 5 women may need further treatment. This treatment may include methotrexate or a salpingectomy. For a woman who had salpingotomy, take 1 serum HCG measurement on 7th day after surgery, then 1 HCG measurement per week until a negative result is obtained. Advise women who had a salpingectomy that they should take a urine pregnancy test after 3 weeks, and advise women to return for further assessment if test is positive. Now, recommendations for clinical practice. When considering a conservative management, patients should be given detailed information about success rate, side effects, and complications. In conservative management, women need to comply with follow-ups and adjust their lifestyle, including cessation of smoking and alcohol, to minimize the risk of complications. In both medical and expectant management, follow-up with serum beta HCG concentration should continue until the level becomes undetectable. Anti-D prophylaxis should be given to all rhesus negative women who require surgical treatment. Future pregnancy should be delayed for at least 3 months after completion of medical treatment because of the risk of teratogenicity of the methotrexate. Here are my references, and thank you.
चलें जी वापस आ जाए कमेंट से। हाँ जी, आप जो हाजरीन है यहाँ पे उनके कमेंट्स कोई। चले मैं अपने कमेंट से शुरू करता हूँ। मैंने शुरू में ही पूछा था कि जी आपने टाइम बताया था, क्योंकि जब आप बताएं कि the patient came on 13th of June, so it should be at 11 a.m. or whatever time, or 11:30. Yeah, whatever time, so that then because this is a huge emergency and minutes count in such situations. This patient had a pulse of 110 per minute and a blood pressure of 100/60, which was not really bad. But the patients can sometimes present with the worst condition, with a higher pulse rate or with greater amount of blood lost. So in those patients, it really matters the time of arrival and then going on to the surgical intervention. You were right that you said that since it was an acute emergency, that's why you were examining while the patient's management at that stage was being carried out simultaneously. Now going back to the history once again, gestational age of 11 weeks. That's a diagnosis. 11 weeks वाला काफी ज़्यादा लगता है, but anyway, the patient is a well-educated person and she has given you that that PV spotting on 10th of May, and she had her beta ECG on 5th of May. अच्छा, आपने EDD बताई थी, उसका LMP था पेशेंट का 28th of March 21. आपने EDD बताई थी 2nd of January 22. वो कैसे कैलकुलेट किया? 7 days ऐड करो, 28th मार्च में कितने बनते हैं? मेरे अगर आप वो 7 days ऐड करके कर रहे हो ना, या तो आप अल्ट्रासाउंड वाली जो होती है कि फर्स्ट ट्राइमेस्टर का अल्ट्रासाउंड है उसने इतना कैलकुलेट किया। अदरवाइज अगर आप निगलीज रूल इसको बोलते हैं, इसमें 7 days प्लस, तो वो बनती है 4th of January, नॉट 2nd of January. बिकॉज अगर आप 2nd of January कह रहे हो तो आप 5 दिन ऐड किया, आपने 7 दिन नहीं ऐड किए. So that makes the difference. Although it does not really matter that much, and on ultrasound, if it were an intrauterine pregnancy and first trimester ultrasound may suggest that the EDD is not 2nd or 4th, it may be 10th of January or it may be 25th of December. But when you apply a certain rule, then stick to that rule, which is 7 days. So you can't really say 5 days of that. That just shows a little bit of carelessness on the part of that calculation, right? Now, pain, lower abdomen, 5 hours, and dizziness, 2 hours. It was a spell of dizziness, or she had been feeling dizzy?
So she had one spell of dizziness, which lasted for 1 minute. But during that spell, she didn't faint or vomit.
All right, all right. And she had then initial 985 beta ECG, no intrauterine sag. Do you really expect to see an ultrasound sag at that time? On 10th of May, she had. 10th of May was how much? She was about 6 weeks. Beta ECG was a little low at that time. So on 18th, then beta ECG 1580 on 18th. It was not growing really at that stage, because if on 10th of May it was 985, I would expect on 13th in 72 hours to double it in about around 2000, and on 16th it should have been about 4000, whereas on 18th it was 1580. That means the pregnancy wasn't doing well, and at that time it should have been, something should have been suspected, and then she got this injection methotrexate on 20th of May. अब ये जो है, do the nice guidelines say that you test the beta ECG on 2nd day after 2 days? general recommendation is that beta HCG monitoring after a dose of methotrexate should be on 4th day and 7th day. If you are following one dose regime, then it is that. If you are following 2 doses, even then it is the same. But then the second dose is given on day 4. Those who give, and sometimes even 3rd dose is given. So you give methotrexate and then assess beta HCG on day 4 and day 7. And on each occasion, you would expect, if it is responding well to that, a 15%, at least 15% decline in the beta HCG levels. जी वकार अली साहब रेज किया हैंड, बताइए प्लीज. वो उनकी आवाज नहीं आ रही है वैसे. और म्यूट है. अगर आप सुन सकते हैं आवाज हमारी तो प्लीज राइट डाउन योर कमेंट. कमेंट लिख दीजिए. All right. So the point is that any precaution or anything that you would do before you give methotrexate.
Sir, first of all, I'll go through that criteria. The medical management there should be no cardiac activity. The max should be 35 millimeter less, and the beta HCG level should be between 1500 to 5000. She should be stable, in stable condition, no pain, pelvic pain, and
no evidence of hemoperitoneum.
Sir, no. Yes, sir, methotrexate से hypersensitivity नहीं होनी चाहिए. LFTs उसके normal range में होना चाहिए. So
you will do LFT and RFTs because it is metabolized in liver and it is excreted in through kidneys. तो ये दोनों systems का आप baseline test करोगे. So one, that the patient should meet the criteria for giving methotrexate, which is the size of the pregnancy or size of that ectopic pregnancy or mass should be less than 3.5 centimeters. And beta HCG should be less than 5,000 units. और and ये तो ये हो गए टेस्ट के साथ, और उसके साथ LFTs और RFTs उसके पहले करवाओगे देने से पहले, and the rest of the condition should also be met. That there shouldn't be any intrauterine consumption.
And sir, willingness for follow-up.
हाँ, willingness for follow-up. ठीक है, good. Your history was good. यहाँ पे हाँ. जब आपने मेंस्ट्रुअल हिस्ट्री बताई है, आपने सारे पॉइंट्स, आपने क्वार्टरल फ्रीक्वेंसी भी कही, कॉन्ट्रासेप्शन भी, पैप स्मीयर भी, सारा कुछ किया, और 5/30 days रेगुलर एवरेज फ्लो, एंड यू हैव ऑलरेडी मेंशन्ड लास्ट मेंस्ट्रुअल पीरियड इनिशियली, बट व्हेन यू वर नरेटिंग द menstrual history, then you should again make a mention of that. That her last menstrual period, as has already been stated, was on 28th of March 21. And the PV bleeding in this patient, yes, there was PV bleeding in this patient. She had spotting on 10th of May, and then after that, she didn't experience that, did she?
She did, sir, and she came initially. That was the symptom when she came to the hospital to get herself evaluated, and then she had beta HCG and scan, but she didn't experience PD spotting after that. It was only one episode.
Only one episode of bleeding.
One episode, yes. Sir.
Right. All in all, I would say that the history and physical examination and description was good. And similarly, I would say that your presentation, that was also very relevant, and I think that you made good points. Mostly you have followed ये वाला जो है nice guidelines of 2019. मैंने वो आज सुबह मैंने देखा, तो मेरे पास था एक ये मई 2021 का कैनेडियन जर्नल में है, सोसाइटी ऑफ ऑब्स्टेट्रिशियन गायनेकोलॉजिस्ट ऑफ कनाडा का वो है ऑब्जर्वेशंस एंड रिकमेंडेशंस हैं. ये इसके साथ हम लगा सकते हैं इसको जरा, वो मैंने वो जल्दी से अपने लैपटॉप से में कर देता हूँ. ठीक है, तो ये मैं फॉर द सेक ऑफ ऑडियंस वाईफाई तो हो गया, इंटरनेट नहीं. कैपिटल में ले लीजिए, एक ही लफ्ज है। इसमें यहाँ पे यही, हाँ तो चलो हम could not join healthcare. Healthcare would not inform. ये इंटरनेट में नहीं चलेगा ये, यहाँ पे आ रहा है। Ectopic pregnancy actually is a condition which demonstrates amply that in gynecology, in most of the instances, you can make a diagnosis on the telephone without seeing the patient. And it signifies in the sense that if a patient tells you that she is overdue by a couple of weeks, and she has pain in one of the iliac fossa, and she also has bleeding, and she is feeling dizzy or something like that, and immediately the diagnosis would be that you would want to rule out ectopic pregnancy. I'm not saying that she has ectopic pregnancy, but that immediately becomes number one differential diagnosis. हाँ जी, अब मैं क्या करूँगा? व्हाट्सएप पे आ गया लिंक। शेयर स्क्रीन कर दूँ। कहाँ पे शेयर स्क्रीन? ये जी वालेकुम स्टैंड क्लास स्टैंड लगता है सेशन चल रहा होता ना फिर नहीं खड़े होना चाहिए। ये थैंक यू जी। हाँ मैंने अनम्यूट किया तो था मैं ये बस 5 मिनट में स्लाइड्स मैंने दिखानी है, अनम्यूट ही है। Yeah, I came across this practice guideline of SOGC, which is equivalent to RCOG in Canada. And Nida very rightly made a comment that she did not include two. One was unknown location and the other was heterotopic pregnancy that she didn't. But this guideline 414, this relates to management of pregnancies of both unknown location and those locations, known locations, that is tubal and non-tubal. And I just thought that the contents would interest you. We'll go, this is from Journal of Obstetrics and Gynecology of Canada, published in May 21. And the summary statements, and it also gives the grading and the importance of that, whether it's high or low. I just copied them. I didn't even have time to read through myself. But these are important points to note that accounts for majority of first trimester maternal deaths because of uh, lack of diagnosis, because of bleeding, and this is coming from a developed country, and its rating is high. Tubal pregnancies, Nida told about the rates, and unknown location is a transient state actually before. You see, till about mid-May, even the patient that she presented the case of, even in her case, the pregnancy was of unknown location until and unless it becomes obvious on ultrasound or at the time of surgery, it is a pregnancy. So that is a transient state till it is diagnosed to be uh, either tubal or ovarian or abdominal or whatever pregnancy. Then management protocols for pregnancy of unknown are predictive and not diagnostic. जैसे जैसे आप उसके साथ जाते हैं उसी के मुताबिक आप देखते जाते हो. So management is first in establishing diagnosis and care of the patient and keeping her under observation at that time. And methotrexate is a safe and effective treatment for carefully selected tubal and non-tubal ectopic pregnancy. Expectant management also, in which you don't even give methotrexate, but in those cases in which you find that there is some tenderness, but the size is not large and beta HCG level is not high, and this is expectant management is something that you, if you give, then you give on, as it is said, that is a carefully selected patients because to avoid the risk of medical and surgical interventions can result in serious morbidity if it fails or if the patient is non-compliant. Sorry. No evidence to recommend conservative tube-sparing salpingotomy over salpingectomy. So salpingotomy, and although this is a moderate one in which one has to make that decision, which she rightly said that if you see that the other tube is also damaged, then and there is an opportunity to make not only salpingotomy, but what here we call it salpingostomy, that you make an incision on the anti-mesenteric border of the tube and milk out or flush out, actually more with hydrodissection, flush out the ectopic pregnancy and leave the uterus as such. Many of us would have seen one or two cases that we can narrate in which this technique proved successful in future pregnancy where the other tube was already damaged and there was a spontaneous pregnancy. At least I recall two patients in whom this was successful. But anyway, this is important that salpingostomy, we call it salpingostomy, North Americans call it salpingotomy. That is can be resorted to, but the problem in those cases is that sometimes you cannot secure hemostasis. If despite that hydrodissection is that you kind of throw a stream of saline onto that, and with that, because that would be gentle, you are not teasing out, you are not handling the tissue as such, and therefore you would expect or in the hope that the whole of the trophoblast would disengage from its attachment and come off it and leave it without any bleeding. One has to be lucky to have that. Otherwise, if there is some bit of bleeding, that can be a source of or reason for a repeat procedure. Ultrasound diagnosis non-tubal ectopic requires experienced sonographers and radiologists, especially if it is not in the tube, then to make a diagnosis that it is with the ovary or elsewhere. Providers should have high index of suspicion for cervical ectopic pregnancy because severe outcomes often occur with delayed diagnosis and management, and that holds true for now cesarean scar pregnancies, which is the newer development. And with the so widespread use of cesarean section, the sometimes we don't even know. We are treating a patient for, say, incomplete abortion because the patient has expelled out something and she was pregnant. And when you perform D&C, I had a patient about 3 weeks back. She bled so profusely that it was terrifying. And I suspect I don't have couldn't have that ultrasound or test at that time to prove that it was a cervical pregnancy, but I strongly suspect that. So therefore, high index of suspicion should be there for cervical pregnancy and particularly scar pregnancy. And these days, if you do find that a scar pregnancy is diagnosed before it bleeds or before you intervene, then the explanation should be, or counseling of the couple and the family should be carried out about the procedure getting on to even the stage of removal of the uterus. Undergoing treatment for cervical pregnancy should be about the risk of hemorrhage and the need for hysterectomy. And the term interstitial cornual pregnancy are used interchangeably in literature. ये जिस तरह से आपने cornual pregnancy कहा ना कि एक वो rudimentary horn में, but cornual pregnancy is cornu of the uterus, single normal uterus, उसके cornu में भी हो जाए तो वो भी है, and if it occurs in a rudimentary horn तो वो उस तरह से भी है.
उसको तो इंटरस्टिशियल स्लैश कॉर्नुअल कहेंगे.
हाँ, लेकिन ये दोनों चीजों ये इंटरचेंज होती हैं, जिस तरह से उन्होंने कहा ना लिटरेचर में कि वो है इस तरह से. Abdominal pregnancies are associated with high rates of maternal mortality owing to high risk of catastrophic hemorrhage. Laparoscopy is often required for definitive diagnosis of ovarian pregnancy. Spontaneous heterotopic pregnancies are rare. That means it is usually part of the assisted reproductive techniques which give rise to both types of. अब recommendations हैं मुख्तलिफ. For tubal pregnancies, these 4 recommendations. Can consider expectant management and a very close follow-up in carefully selected patients, asymptomatic tubal pregnancies. If a patient meets the criteria for medical management of tubal pregnancy, we suggest single or double dose methotrexate protocol. If feasible, clinicians should use a minimally invasive approach in the surgical management of tubal pregnancy. Consider both patients and surgeons factors when deciding between salpingectomy and salpingostomy. There is no evidence to recommend conservative tube-sparing salpingostomy over salpingectomy when the contralateral fallopian tube is normal. फिर तो सीधा सीधा से वो कर देना चाहिए. Cesarean scar pregnancy, consider medical management with multi-dose and or local methotrexate as a safe and effective treatment in appropriately selected women. Should consider treating type 1 cesarean scar pregnancy surgically with hysteroscopy. Clinicians should consider treating type 2 cesarean scar pregnancy surgically with laparoscopy with removal and excision of that area and then repair like one would do in during the cesarean section. Cervical pregnancies, appropriate cervical clinician should offer medical management over surgical management with dilatation and curettage. Medical करना चाहिए, surgical. Interstitial corner, offer conservative medical management with multi-dose methotrexate, or surgery is required because surgery again in this case would be kind of rather more than ordinary surgery. It would require removal of part of that cornual wedge resection because both procedures have comparable results: cornuotomy, laparoscopy, or cornual wedge resection. Either laparotomy or laparoscopy to excise an abdominal pregnancy. May offer conservative medical management of ovarian pregnancy, methotrexate form, laparoscopic ovarian wedge resection rather than oophorectomy for ovarian ectopic pregnancy if clinically. Heterotopic should not offer systemic methotrexate, and we suggest surgical excision of ectopic pregnancy in cases of hetero. If the intrauterine pregnancy is not desired, we conditionally recommend additional dilatation and curettage to the surgical procedure to evacuate uterine cavity. ये थी जी, ये इनकी हैं recommendations ये that we I can make available on that. Thank you very much. If there are any comments, please do write them on this in-call messages board.
सर आवाज़ नहीं आ रही. सर आवाज नहीं आ रही है। सर आवाज नहीं आ रही।